My name is Dr. Song. I'm one of the general psychiatrists and child and adolescent psychiatrists at Mill Creek Community Hospital. I work over at Corey Counseling as well. So I appreciate y'all for coming out today and attending the lecture. So today we're just going to go over mental health care in the rural community, just to understand the services and kind of what's out here. A lot of questions that clients will frequently come up with is, they're just unsure of what's out here. And so just having that discussion about maybe common types of mental illness and just the services that are available in the community out here. So in this lecture, we'll go over an introduction to mental health, background and information, just within the last few years, looking at statistics, looking at maybe specific disorders that you may see more commonly, depression, bipolar, schizophrenia, more of the major mental illnesses that we can see. Addressing the stigma of mental health, looking at the access to services in the rural setting, which we are in. And then lastly, kind of the role of Corey Counseling, which we are lucky enough to have some staff here representing the Counseling Service Center. So again, my name is Brenton Song. I'm a 2018 graduate of LECOM at Seton Hill down in Pittsburgh. I did my residency in general psychiatry in Mill Creek Community Hospital for 3 years. I finished my fellowship in child and adolescent psychiatry last year, so I'm still pretty green at this. So just the training wheels are off, and I do work in the hospital at Mill Creek in the inpatient child and adolescent unit, and I do work in the clinic over at LECOM as well as the Corey Counseling Center. So I'm the new guy out there. I do have 2 boards in general psychiatry and child and adolescent psychiatry, which is, I guess, a slightly pretentious way of saying sometimes I know what I'm talking about. So there's that. So looking at the introduction and background, I think it's important to look at statistics, look at some of the issues that we're facing in mental health, particularly within the last few years. Suicide is the 10th leading cause of death in the United States. Cancers, diabetes, COPD are lower on the list. And so you can see that suicide is very prevalent in the United States. It's the 2nd leading cause of death for patients 44 and under. The 1st leading cause is actually accidents, so preventable injuries, motor vehicle accidents, ATV accidents. So you can see it's a major cause of death of young people. In the demographic 45 and 54, cancers, homicides, those are things that are above suicide, but you can still see it's within the top 5 causes of death in that age demographic. I thought it was an interesting statistic that more than 40,000 Americans die annually from suicide, and that was statistics from this year. Just to give kind of some relevance to that, the census in 2013 had Corey at about 6,100 residents. So you can see, 5 or 6 times, Corey, that's the amount of Americans that die annually from suicide. So it's a huge amount. As far as the census in 2023, about 21% of adults in the U.S. experience at least one mental illness, whether that was depression, anxiety, ADHD. About half of that did not receive treatment, unfortunately. So about 25 million did not receive any treatment, and 12.5 million they experienced what's called a severe mental illness. So the severe mental illnesses we define as major depressive disorder, bipolar disorder, schizophrenia, borderline personality disorder are the 4 serious mental illnesses. So you can see kind of from the statistics that although there's 50 million adults experiencing that are identified with a mental illness, only a quarter are identified and treated.
Would you say that the 55% is due to not being able to access the services or just not going for services? I
think both. I think people aren't aware of maybe the services. There is some stigma, unfortunately, against mental health. And I think there is an access issue as well, especially in the rural community. Looking at kind of the child and adolescent statistics, you can see there's been a huge jump since 2007. It puts them at a very high risk of a comorbid substance use disorder, whether that's marijuana, alcohol, even nicotine. So you can see that, their mental illness will kind of project their risk of substance use. they ballparked around a fifth of all teens suffer from depression. It's not maybe a major depressive disorder, but a form of depression by the time they reach adulthood. Every 100 minutes, a suicide occurs in the adolescent population. The top 3 causes of death in this age demographic are accidental injuries, again, so like motor vehicle accidents, ATV accidents, things like that, homicides, and then suicides. So you can see it's a very prevalent, unfortunately, in that age demographic. I think it was important to at least look at selected disorders. People will say, depression, bipolar disorder, schizophrenia, but maybe looking at maybe the diagnostic criteria. I go over this with the residents in the hospital when we go over kind of teaching didactics, so I think it's useful to at least review some things. Going over major depressive disorder, you can see it's about 20% lifetime prevalence. Approximately 7% of adults in the US experience a depressive disorder any given year. The number that I could find in the census was 365 million adults in the US. So you can see that's about 65 million that will experience a major depressive disorder in any given year. By the numbers, major depression is more common in females than males, whether that's just the male stubbornness to go get help and get identified, but the numbers do skew more towards females. I think you can see a lot of prodromal factors in the younger years, but usually the prevalence is the highest in young adults, so about 18 to 25. Usually that's when the first episode of major depression will happen. I stress to the residents when I work with them that there's a big social impact about depression. It's not always about getting them diagnosed and treated, which I think is obviously very important, but looking at how that impacts them socially. So you can see relationship issues if you have a partner who, very depressed, won't get out of the house. You're going to have to dedicate more resources towards them. That can cause a lot of strain in the relationship. They're going to withdraw socially from family, friends, which is also going to kind of cause a strain with other people. There's going to be a decreased work productivity. So they're not going to really go to work because they're going to be kind of isolating, calling off work. There's going to be an impairment in the occupational functioning. I think with that, you can kind of extrapolate that there's going to be an issue financially. If you're not working, you're going to have more financial issues as well. And of course, there's the increased rate of healthcare utilization, whether that's through an inpatient hospitalization, use of outpatient services, partial hospitalization services. So you can see not only is it difficult in any sort of relationship with friends, family, significant others, you're going to see impairments in kind of a work setting, an occupational setting, as well as increased use in the healthcare system. This is the diagnostic criteria for major depression. We use the mnemonic SIGI caps. So these are kind of the things that we look for in a depressed patient. We look for sleep disturbances, which typically is less sleep or less restful sleep. The fancy word is anhedonia, but that's just kind of a fancy way of saying decreased interest in things. They have hobbies that they like, but they don't really engage in those hobbies. I have clients that kind of tell me, I like being outside, I like fishing, I just can't get myself to get out and, get the rod out and get out there. You can feel very worthless, low energy, problems with focus. You can see typically a lowered appetite, just food doesn't taste good, you're not going to really eat too much, and that you can see kind of weight changes as well. In terms of suicidal ideation, it's not always, floridly suicidal with a plan. Some people describe not waking up in the morning, it'd be better off if I wasn't here, passive thoughts of death like that. And so you can see kind of globally, you're seeing someone that's more withdrawn, low energy, difficulty functioning. Risk factors, definitely a family history is very significant for the development of major depressive disorder. Numbers kind of indicate that it's about 40% more risk if you have a first-degree family member diagnosed with major depression. So if your mother, father, brother, sister were diagnosed with depression, it puts you at a higher risk. Certainly brain chemistry, which we look to target with psychotropic medications, plays a link. I think obviously that's not kind of a catch-all, because theoretically if you were to treat with an antidepressant, you would see full remission of symptoms. So I think there's other things that, in addition to the brain chemistry, life stressors, there's usually something that, the straw that breaks the camel's back, as they say. When the residents will kind of talk with me about, this is what happened and this is what caused the depression, usually I'll talk with them about getting more information. It's usually an insidious onset. It's not usually, this happened and I'm depressed. It's usually, my dog died, but then I lost my job, I was drinking a lot, I had issues with my family members, I broke up with my boyfriend or girlfriend. So there's usually a progression of stressors that kind of lead up to, kind of one final thing that happens, and then you see the progression of depression. Chronic illness is definitely a risk factor for depression. If you can think about, arthritis, heart issues, trouble breathing, COPD, if you're in chronic pain, it's going to put you, very debilitating. It's going to impact your mood, so it puts you at a risk for depression. Bipolar disorder is another famous kind of disorder, one that we treat fairly often. So we just talked about kind of a unipolar depression, so one, bipolar depression being up and down. I think a lot of people kind of self-diagnose bipolar, I'm manic depressive, I go from really happy to really sad. We look at kind of prolonged periods of moods. If you kind of went, minute to minute, that'd be very, very different than what we see with bipolar disorder. If you see, if you've all been to McDonald's and see the ice cream machine, you get really happy, and then it's broken, you're like, oh, I'm really sad. It's not really bipolar disorder, even though you went up and down. What you see in bipolar disorder is, periods of weeks to months even, where you have, changes in moods between what we call mania, hypomania, and then down to a depressive mood. So you're vacillating between the highs and the lows of bipolar disorder. Typically, we'll see kind of a first episode within late adolescence, early adulthood. It's very rare to have kind of a early childhood manic episode, though it does happen. It's less than 1% where you do see that. It's very hereditary, as high as 80% risk, increased risk factor if you do have a first-degree family member diagnosed with bipolar disorder. So, one of the things that we do tend to screen when we look at clients with a possible bipolar illness is looking at your family members, mom, dad, brothers, sisters, cousins, because that puts you at a significantly higher risk of having the disorder. There's no single bipolar gene as of yet that we've identified. There are a few that are kind of under investigation, brain-derived neurotropic factor, the serotonin reuptake transporter, the dopamine reuptake transporter. So there's different kind of genes that we think may be linked, but there's no single gene that if you have this, you have bipolar disorder. But definitely you can see that from the numbers, it's very hereditary, and it can be linked with families. Complications, it can be pretty difficult to tell someone who's floridly manic that they are manic because they're maybe not thinking very clearly. It can be very difficult to kind of have maybe a rational conversation with them because they may be all over the place. As far as comorbidities, it can get a little muddy, to say the least. In terms of common comorbidities, ADHD is very common in about 60 to 70%. A substance use disorder can be present in as high as 75 to 80%. So whether that's use of methamphetamines, alcohol, marijuana, they're going to tend to self-medicate to kind of help control their symptoms. As far as medical comorbidities, someone with bipolar disorder is more inclined to do kind of what feels good. So they're going to eat, what they like. They're going to do kind of whatever they like, which can be, possibly unhealthy. So they're at a higher risk of medical comorbidities, breathing issues because of cigarette use, heart issues because of poor diet and exercise, things like that. It's kind of an older study I pulled. This was back in 2018 when the study was done and published in 2020. So it's a little older. But I thought it was interesting that the cost per patient, per average patient per year with bipolar disorder was about $21,000. So that ballparks back in 2018, that was $195 billion spent just on patients with bipolar disorder. So you can see that, we talked about the increased use of healthcare systems in depression. You can see patients with bipolar disorder will, utilize the healthcare system, as necessary, but it's costing, a lot of money. Just as we looked at SIGI caps for depression, this is kind of the criteria that we use for bipolar disorder. So you can see distractibility. They can be very hard to kind of focus on things. They're kind of jumping from kind of topic to topic. Impulsivity, they're going to do what feels good. They're going to think that spending $5,000 on, a new business is a great idea, even though they just started one last night. Grandiosity, on top of the world, I feel invincible. I feel good, nothing can hurt me. Again, kind of with that impulsivity can lead to a lot of bad decisions. Flight of ideas is kind of a way we used to describe kind of jumping from topic to topic, not necessarily related. So that can kind of give the impression that they're kind of all over the place. It can be hard to kind of have a linear conversation with them. So instead of, I got in a car and drove here and came to this lecture, it's I got in the car and then I ate some food and then I jumped in a plane and then I started my business and now I'm here. So it's kind of difficult to follow what they're saying. In terms of activity and sleep deficit, people with bipolar disorder need very little to almost no sleep. The difference between kind of mania and hypomania is the amount of sleep that they need. People with a truly manic episode can stay awake for 7 or more days. The most I've heard is about 10 to 14 days where they've needed maybe 2 hours of sleep a night, and they were kind of floridly manic. Pressured speech, so like talkativeness, it can be very difficult to follow because you kind of feel out of breath just listening to them. They can talk very quickly. It's almost like their thoughts are so fast they can't get out of their mouth fast enough. And so with their kind of flood of ideas, you can just kind of be taken aback trying to follow their conversation. That can be difficult. Again, socially, you can see that it impacts kind of relationships with, others. Someone who's manic, hypomanic can have issues with mood swings, can put pressure on the relationships between their partners, family members. It's difficult to kind of keep good relations with people. Employment, as you can imagine, as much as you think someone who doesn't like to sleep could be a great employee, they're pretty hard to stay on track. So they tend to not be able to hold jobs very well. And legal issues. Because they're kind of having impulsive behaviors, kind of doing what they want to do, they're not thinking very clearly, their executive function is not great. They can get into a lot of trouble with the law, breaking into things, stealing things, and so they can get involved with the police as well. And the last disorder I want to go over, schizophrenia, something that we commonly see, unfortunately. It's one of the top 10 illnesses according to the WHO, contributing to the global burden of disease, along with heart disease, cancers, things like that. So very prevalent, unfortunately. It's associated with impairments in social and occupational functioning. So again, the social functioning would be your issues with family members, with friends, and your occupational functioning, whether that's in school, at work. You're seeing vast impairments there. So kind of in a nutshell, it's a disorder that prevents people from maybe thinking clearly, having linear thoughts. But the difference between that and bipolar disorder is that there's the presence of hallucinations, delusions, and disorganization as we kind of describe it. Typically, we'll see kind of a first break psychosis, which is your first episode in early adulthood. So similar to mania, hypomania, you're going to see the first episode in early adulthood. Major depression, as you remember, there was more females than males. Schizophrenia kind of evens out a little bit more, so you see more of an even distribution between males and females. In females, there's what's called a bimodal distribution. So in males, you're going to see that first peak where you're going to have more patients with a first break in early adulthood, which is the same for females, although there's a second peak that happens in the 50s as well. And so it's not unheard of that, a female in this age demographic can come into the hospital with a first break psychosis. Comparatively, if someone comes in that's that age demographic with maybe a first break mania or hypomania, typically we look at a comorbid substance use that's attributable to the manic or hypomanic episode. So we split the symptoms into positive and negative type symptoms. When I kind of teach the subject, I go, positive symptoms add to things, where negative symptoms take away from things. So positive symptoms, you're adding in hallucinations. I'm seeing people outside my room. I hear the TV talking to me. Delusions, people are after me. My boss is out to get me. Thought disorders, you can see what's called thought blocking, which, if we were to have kind of a back and forth conversation, it would be kind of, it would have some sort of rhythm. Thought blocking is they just don't respond, or they have a hard time responding. There's a big delay in their response. Whereas if you look at the negative symptoms, you're kind of taking away things. So their affect's flat, they don't show a lot of emotion, they don't talk very much, they kind of self-isolate, and so you're taking away symptoms from them. This is a CT of a brain, obviously. On the left, you have kind of a normal control. These are called ventricles in the brain. On the right side, you have someone with schizophrenia. It's one of the kind of few disorders that we can see CT and MRI changes. So you can see with the client with schizophrenia, they have enlargement of the ventricles, which is characteristic of a client with schizophrenia. And you can see it's very pronounced in this case. I thought it would be interesting to present. So looking at, I think, the stigma of mental health, unfortunately, kind of in all areas, there is kind of a worry about addressing mental health and getting that looked at. So looking at the numbers, within the last 18 to 24 months, suicide rates in people in rural areas approach about 20 per 100,000 residents. In urban areas, Pittsburgh, Cleveland, Buffalo, you're going to see almost half that, which kind of demonstrates that people in the rural area are at a much higher risk of suicide. Unfortunately, you can see that most rural counties lack access to a psychiatrist, access to a nurse practitioner, and about half lack access to a psychologist. So you're seeing a lack of access to services for not only medication management, but also diagnostic assessments and even therapy as well. Some barriers that seem to be common in addressing mental health. The fear of embarrassment, I think, there's maybe generational, thoughts that, seeking mental health care is weak. It's not something that you're supposed to do. You're supposed to kind of muscle through it. I wish that I could tell you that I haven't worked with patients recently that haven't said that, but unfortunately that's still kind of the case. There is the fear of lack of anonymity. It's a small town. Everybody kind of knows everything about everybody, or someone that knows somebody else. So there is the fear that, hey, I saw so-and-so walking out of the counseling center. They must be quote unquote crazy. So that I think drives people away from seeking access to care. Like your question was kind of talking about, there is a shortage of mental health professionals. There's not a lot of us per the need of other people. So there is lack of access, as you could kind of see from that last slide too. Affordability, the numbers that I pulled, that the average salary in Erie County was about $40,000 to $45,000. When your copay for medications could be as high as $400, $500, you're just not going to go get services and get help. So affordability can be a factor in terms of paying for copays for therapy, getting medications covered. That can be a big barrier. And transportation. A lot of people don't drive. This is obviously kind of not a great area in the winter. And so transportation can be a barrier, kind of making it to a clinic, making it to be seen for your medication checks, making it for therapy. That can be difficult. Honestly, there can be a lack of understanding even for, staff in healthcare. There's obviously the medical side and there's the psychiatric side. And, I like to say we kind of play well together, but, both sides have, things they specialize in, and, we don't know everything. We try to kind of delegate to who's appropriate. And again, there is kind of a prejudice or stigma towards people with, mental health disorders. I think we kind of fear what we don't know. Aunt Sheila's crazy, but, Aunt Sheila maybe had a death, her husband died a month ago, and then her dog died, and she lost her job. And so, those things may have contributed to things, but, we kind of have this stigma about, different people, and cause us to kind of feel very uneasy about it. Again, kind of reinforcing the fact that it's a small community, and there may be the fear that your information isn't kept private, because there's not a lot of people here. Again, there's about 6,000 people in the city, so it's very small. So that's kind of the barriers that I've identified for the stigma of mental health. This was a study that I pulled from the American Psychological Association that was published last year. But they polled a number of patients. They said 81% for both rated that they were in good physical and mental health. Although during examination, 66% were told that you actually do have a physical illness, and about 37% were diagnosed with a mental health condition, despite kind of feeling that they were doing well. And it was kind of adjusted for pre-pandemic and post-pandemic levels. So what this kind of showed, at least to me, was that, hey, everything's fine, I'm fine, I don't need help. But in fact, there may be some other things going on. And it's a pretty high percentage as well. Any questions so far? Okay. So looking at the needs and access to services, or things that we do to kind of help promote or kind of, be able to have people be able to access kind of services out in rural communities. We do utilize telehealth, telepsychiatry, so it allows us to, use any sort of media with a camera, so we can use a telephone, a computer, a tablet, things like that, to kind of connect a practitioner with a client. So if a client can't leave the home, can't make it out of their home to come to the clinic, bypassing the transportation kind of barrier, we can get them seen by telepsychiatry. To be honest, it's not my favorite form, because you can kind of see from the chest up and you're kind of missing everything from the chest down, which is a lot. But I think kind of the pros and cons of it is, being able to kind of see a client, get them connected to services. I think anything at this point is better than nothing. There are school-based services, and so, obviously I'm biased towards Corey Counseling, but, we do have school-based services that go to the individual schools, at least in the Corey area, so to the elementary school, the middle school, the middle high school. It's a team of, we work with the school counselors, psychologists there, there's social workers that kind of help coordinate services with students in the classroom setting. I think a benefit of that is, unfortunately, there are kids that I work with that, the parents don't really believe in mental health, unfortunately. And so they would never be able to be seen if they weren't seen at school. So the school-based service is helpful in the fact that they can be seen at school. Parents don't have to get off of work, drive them to get services. That's very helpful for a lot of clients.
So with the school-based services, is it based like the school pays for it, or is it based on managed care, the insurance?
I couldn't tell you who pays for it. I could find out for you, for sure.
Just curious, I know that's an issue.
For sure. Integrated care models, I think ideally they found good data that kind of had a psychiatrist or a mental health professional in with a primary care physician. It's going to help liaison between treatments for mental health. Primary care physicians are the #1 prescribers of psychiatric medications, which makes sense because there's a lot more of them than there are of us. And so they're going to be prescribing a lot more antidepressants, and having maybe someone who's trained with the medications can be helpful in terms of an integrated care model. Community health workers, so there's advocates in the community that kind of talk to, give speeches, hold kind of seminars, almost things like this where we can kind of discuss mental health, which is very helpful just to kind of increase awareness and knowledge. Even community partnerships, stores kind of advocating for mental health treatment, mental health awareness, it's very, very helpful. So, I work at Corey Counseling. I've been there for, the last about 8 months or so. Unfortunately, the staff are, have to put up with me a couple days a week. But we are kind of a team that tries to just kind of provide supports for the community, whether that's medication-based, therapy-based, coordination of care, blended case management services. And I think this is kind of an important topic to go over because, to us, kind of that work in the field is like, well, you have this, this, this. But, to someone who's maybe not familiar with kind of mental health, you just kind of don't know. And so it's helpful to kind of go over the services, spread the word that, these things are available for you, so people have an understanding of things. So this is the official plug for Corey Counseling. We've been there for about 40 years. I think, in a nutshell, we're trying to provide professional and caring mental health services for the community. Provide access to services for everyone here. So looking at some of the services, there's family-based mental health that we have over at the clinic. It's been there since 2008. It's a very intensive form of outpatient therapy for clients. For children and adolescents that are high risk for displacement from the house. So if they're at a risk for residential or removal from the house, family-based